Okay, good morning, everyone. And thank you for coming. I am not Suzanne Mazer, so don't be confused. Today we are going to be introducing you to our 2016-2017 QI Scholars class. They are going to be telling you about some really interesting and great projects they did during their time in the QI Scholars program. I am the director of the program, and so I'm going to give you, start out by giving you a little bit of an introduction to the QI Scholars program. Then I'm going to tell you a little bit about each of our scholars. Then the meat of our presentation is to hear each of them give a 10-minute presentation on the research project that they did during their time in the QI Scholars program. It's a kind of a 10-minute PAS-style presentation. We're going to ask everybody to hold your questions till after all four people have presented, and we'll bring them down. And at that time, you can ask them questions about their projects, questions about being in the QI Scholars program, or just about the program in general, okay? So, first of all, what is the QI Scholars program? Our objective of this program was really to increase our faculty's expertise related to rigorous, and by that I mean publishable evaluation of our quality improvement activities here at Seattle Children's and throughout the department. There's three parts to the program. There's a mentored QI research project that the scholars complete during their time in the program, or maybe it goes a little over their time in the program, which is okay. There's seminar attendance, so monthly seminars over a one-year period. And then each of the scholars does quarterly presentations and attends a work-in-progress session where they're able to give each other advisement on projects, and all of the QI Scholars faculty attend those quarterly meetings also. So a little bit more about the research project. Like I mentioned, it's a mentored research project. So each scholar at the beginning of their time in the program is paired with one of our QI Scholars program faculty who has experience in QI research methodology. And they are required to meet with their mentor twice a month. And their mentor really, the role of the mentor is to assist them with designing their project, identifying and obtaining data to actually answer the research question that they've posed, interpretation of their data analysis, and then drafting and refining of their manuscript. There's also a fair amount of analytics support that comes with program participation. Scholars and their mentors meet with their team for statistics. They have a statistician and a program analyst. They meet with that team about once a month on an as-needed basis. And then each scholar is also given 100 hours of data analyst time to help them with completing their program analyses or their project analyses. So our seminar series, as I mentioned, there's 12 monthly seminars. They really go over state-of-the-art QI research methods. Attendance for scholars at these seminars is required. 6 of them are given by outside speakers from Cincinnati Children's, University of Michigan, Harvard School of Public Health, and Kaiser Permanente. And then 6 are given by our internal QI Scholars program faculty. This is the list of our seminars that are being given this year and were also given during the year that the scholars will be presenting attended. So it's a real great survey of QI research methods. They start out very basically with QI fundamentals, an introduction to statistical process control. As the year goes on, they get into more complex topics like assessing cost and cost effectiveness, decision analysis, interrupted time series analysis in QI research, and also importantly, assessing and improving disparities using QI research methods. So a very broad exposure to different QI research methodologies. So who's eligible to be in this program? You're eligible if you are an assistant or associate professor on the clinician educator or clinical faculty tracks. You have to be able to commit to 1 year at a minimum of 10% FTE. The program provides $15,000 towards that 10% FTE. For many, that is not going to meet 10% of their FTE, and so there has to be a commitment from their division to make up the remainder of the salary so they truly have 10% protected time to both do their project and participate in the program. And our application requires a letter from the division head stating that they'll have that commitment. And they have to have a faculty position. So if there's a fellow you're thinking of who you're bringing onto faculty and you know they're going to have a position starting this upcoming academic year, they would be eligible to apply for QI Scholars, but we again have to have a letter that makes it clear that they do have a faculty position. Okay, so now I'd like to introduce you to our 2016-2017 QI Scholars. First is Sarah Connell. So Sarah, many of you may know, she trained here in pediatric residency. After completing her residency, she worked for 2 years as an outpatient pediatrician for Public Health Seattle and King County. And then she joined our faculty after that in the Division of Hospital Medicine. And during that year that she was in Division of Hospital Medicine, she did the QI Scholars Program. She got bitten by the QI research bug so badly that she left faculty and is now a health services and a quality of care research fellow in our department and a clinical instructor in hospital medicine. Her research focuses on improving mental health outcomes for vulnerable children. Second is Arthi Bhatt. Arthi earned her MBBS from Lady Hardinge Medical College in New Delhi, India, and completed her MD in India, followed by a couple of years of faculty in general pediatrics and in cardiology, also in India. She completed her pediatric residency training and cardiology fellowship at UCSF and a research fellowship at OHSU. I can say that, okay. Arthi is currently an associate professor in the Division of Pediatric Cardiology, and her special expertise is in echocardiography, which she performs in the outpatient, operating room, and cath lab settings. Next is Rebecca Jennings. Rebecca went to medical school at University of Pennsylvania and stayed there for her pediatric residency at Children's Hospital of Philadelphia. She initially joined Seattle Children's as a regional hospitalist at Providence St. Peter's in Olympia. She joined our Department of Pediatrics in 2016 and is an assistant professor in the Division of Hospital Medicine. Her research is focused on improving the quality of care for children hospitalized at community hospitals. And last but not least is Julie Brown. Julie is a Canadian who bounced back and forth over the border numerous times during her training, but she finally landed here at Seattle Children's Hospital about 20 years ago to complete her pediatric residency and has been here ever since. She is an associate professor in the Division of Pediatric Emergency Medicine, and her special interests include anaphylaxis, foreign bodies, and minor procedures. So with that, we're going to bring up Sarah Connell, and she's going to talk to you about her project.
Thank you, Rita. Good morning. For the next 8 to 10 minutes, I'm going to talk to you a little bit about and give you some of the initial results from my QI Scholars project. My project asked the question, how has the Affordable Care Act affected pediatric inpatient mental health length of stay and readmissions? For a little bit of background, I'm going to bring you back to 2014, when the majority of the Affordable Care Act provisions were implemented. There's a couple in particular that I'd like to highlight. The first is Medicaid expansion. We expanded to 138% of the federal poverty level. The second is the essential minimal coverage, including mental and behavioral health, went into effect for all insurance plans on the marketplace. Two other items worth mentioning: marketplace exchanges went into effect, and also individual mandates and employer mandates took place that year. Bringing it home to Washington State, this is a graph up here of children enrolled in Medicaid in Washington State. You can see just in green the outlines on this graph, or the lines on this graph, represent the time period for my study, and I just wanted to highlight that, and also, in addition, the increased rate of enrollment in Medicaid right after January of 2014 when the provisions rolled out. Our hypotheses for the study were that following implementation of the Affordable Care Act, or the 2014 provisions, inpatient mental health length of stay would decrease overall, and then also by insurance type. Additionally, we hypothesized that 30-day inpatient readmission rates for mental health conditions would increase overall and again by insurance type. The methods for my study, we looked at patients, pediatric patients who were admitted here to Children's to the behavioral medicine unit between October of 2011 and September of 2016. We measured their length of stay, how long they were in the hospital. We measured their readmission rate monthly. We looked at insurance types, and we also looked at covariates, including medical and psychiatric comorbidities. The analysis I got to select and had fun with because of this program was Interrupted Time Series, which is a quasi-experimental design and took advantage of the natural experiment or the policy that went into effect in 2014. Often ITS is used to look at policy changes, or it can be used to look at an intervention. We looked before and after, and we were lucky to have many months before and after to look at time points around the rollout. A few of the results, just to highlight the point I wanted to show is just that before the Affordable Care Act rolled out, you can see that 32% of the patient population that was admitted to the PBMU was on Medicaid. After the Affordable Care Act rolled out, that went up to 40%. Looking at a couple of my covariates, we see not as significant a change, but still those with depression or depressive disorders, before the Affordable Care Act rolled out, there was a smaller number of that population. In those with disruptive disorders, we saw, there was a smaller number that went up after the Affordable Care Act. And those with disruptive disorders, the total number of those patients went down. For those with a medical comorbidity, that is any diagnosis during their inpatient stay that was not a psychiatric diagnosis, we saw an increase from 50 to 54% around the time of the rollout. And those also discharged on antipsychotics, we saw an increase from 25 to 29%. And we use discharged on antipsychotics as a proxy for severity, which other studies have done. To review a few of the ITS graphs, this is length of stay, and I just wanted to first point out the upper graph you're looking at is overall. These are all 4,000 plus patients that came into the PBMU from October of 2011 through September of 2016. And you can see before the Affordable Care Act that we have, looks like starting around 7 days was the average of the mean length of stay back in October. We see a small significant increase in overall length of stay. After the rollout, you'll notice that we see a significant decrease in overall length of stay for our entire patient population. When we stratify by insurance type, which we hypothesize would be an effect modifier, we see again that we have a slight increase in both those on Medicaid and those paying by other means. Those on Medicaid have a slightly higher length of stay overall. Again, after the Affordable Care Act rolled out, we see that both those on Medicaid and those paying mostly privately, most with private insurance, overall their length of stay decreased. Those on Medicaid had a more significant decrease. For readmission rates, before the rollout of the Affordable Care Act, we see a steady slope. We see on average around 6% of our patients came back each month. Again, after the rollout of the 2014 provisions, we see a jump to 10%. And one of the neat things about ITS is that you can look and compare slopes over trends over time, but you can also compare right pre and post at that intercept or that intervention. When we stratified by insurance type, again, we see what looks like a fairly stable slope, although those on Medicaid had a slight increase before the rollout of the Affordable Care Act and their readmission rates. What was really interesting was that after the rollout of the Affordable Care Act, we do not see an increase in those on readmission rates of those on Medicaid, but instead we see a significant decrease in those patients returning to our hospital. To recap, subsequent to the implementation of the ACA, we saw a declining mental health inpatient length of stay, especially for those patients insured by Medicaid. And this was statistically significant. We also see a possibly increasing 30-day readmission rate by children, mostly on private insurance. And we see a decreasing 30-day readmission rate among children with Medicaid. Some preliminary interpretations. Again, with policy, it's hard to know exactly what the cause of these changes that we're seeing is, but one might theorize that the length of stay in both private and Medicaid patients after the ACA implementation decreased because of increased scrutiny for need for inpatient treatment and or because of limited bed space. The differences in trends we see for readmission rates between those on Medicaid and those paying privately or by other means after the Affordable Care Act may be due to differential use and or availability of services outpatient. To help inform us, we plan to develop a multivariate model adjusting for our covariates. We also plan to obtain data on mental health inpatient volumes and bed availability during this time. And we'd also like to analyze volumes in the disposition of our children with mental health needs who are coming to the emergency room. Thank you.
Wow, Sarah. I don't have quite as many results there. So I'll make up for time for my entire team. That's what I've been doing this entire year. So I'm from cardiology, and here's my topic: improving echocardiogram measurement accuracy and reporting in pediatric population receiving cardiotoxic chemotherapy. Thank you to Rita for finding me a mentor who has the exact same name. It's not very hard back home in India, but it's pretty difficult here. But she did it. And so I have my mentor, Aarti, who is basking in Hawaii while I'm sweating it out here. So thanks, Aarti. So for a little while she was out, I will point out that I had another name alert, and it just struck me this morning when Rita was introducing. She was my mentor while Aarti was out. And we have the same alphabets, just, whatever that word is called, just mixed around. Okay. So transthoracic echocardiograms, also called ultrasound of the heart, is common and routinely performed to assess cardiac function in oncology patients, especially those who are receiving cardiotoxic medications. So this out here is just a still of what's called a left ventricular short axis view. And you can see that, there's that image. It's certainly not moving in this particular clip. And these are linear measurements that we make, and then we derive fractions and percentages of this, and those get reported out and are used by our colleagues, oncologists, who will then use those numbers to dictate the continuation of their protocol or the modification of that. So this can be in a particular subset with declining systolic function, or where those magic numbers are kind of trending down. This can be quite an important issue. As you can imagine, if chemotherapy is modified or stopped, this can lead to inadequate tumor control or failure to achieve remission. That's really not ideal at all. On the other hand, if chemotherapy is continued at the same rates and without any modification or addition to that regimen, as you can imagine, that would lead to irreversible decrease in cardiac function. We're at this point where we have a huge number of cancer survivors, and one of the biggest morbidity as well as morbidity factors in them is actually cardiovascular. So we know the clock starts ticking right early at this point. So now that we are cognizant of it, I think it kind of brings this project a little bit more into the light. Our aims were to improve the quality of echo studies. Echo is short for echocardiogram, or as I said, the ultrasound of the heart. To improve the quality of echo studies performed by our sonographers on oncology patients by implementing a standard protocol for acquisition and measurement over the period of a year. To improve the quality of echo reports, so this is now reporting for oncology patients by implementing, again, a standardized reporting checklist over a period of a year. Lastly, to improve communication with oncology providers about comparison findings from prior studies. Again, the trend is really important to our oncologists to interpret how the myocardial function is performing over time. And so a comparison finding, we think, is really important to really interpret these findings, and also communication between us sitting in dark rooms and looking at these echocardiograms with our oncology providers and finding out exactly what the patient was doing at the time the echo happened, and whether that might in any form have impacted the numbers that we are then generating for them, which they are then taking into account as they modify these regimens. So in essence, we were aiming to improve imaging, improve reporting, and improve communication around this very critical finding. And to do that, the interventions we plotted were to develop an imaging protocol. Now, we do have a protocol that preceded this particular project, but we were trying to tweak it to make it more user-friendly. A measurement protocol. So this is really, again, it's not like we were not making these measurements before, but to protocolize these measurements so as to allow all of us to make the same measurements at the same spot and have a whole lot of agreement between where exactly we were measuring. And to do all of this, we aimed to sort of tape this out to our groups with educational sessions. To improve reporting, we did this time-honored thing, which is developing a checklist. Are we including all those critical components within our report? And of course, the meat of this project is to increase our reproducibility and decrease the variability of measurements. To improve communication, we hope to have a comparative statement in a very large, if not 100%, of all the patients who had had a previous echo before that particular echo, and where pertinent, a call to the oncology provider. So this is kind of a cut-paste modification of what ended up being a single 8x11 checklist and protocol. These were components of which views were expected from the sonographers to really go down in an orderly fashion. These are linear measurements and derived measurements that we all standardly do, but we were now putting it in the form of a checklist. Then this piece of paper kind of gets evoked in the morning huddle in the echo lab, and it gets filled in with the patient's medrec number and the date of the service. And the expectation was that the sonographer would review the prior echocardiograms, look at this checklist before going into echo or image the patient, come back out and fill in whatever they were able to achieve, and then pass on this particular sheet of paper to the echo attending, who again would go through the same process and make sure we were happy with all the images that we acquired in the order that we got it. And the last bit you see is quite subjective in terms of, was this a technically adequate study? Adequacy we defined as were we able to accurately make measurements of it? Was the acquisition complete, which we defined as, did we get all the images we need to get a good representation of what the heart is doing? And of course, the measurements, did we make all the numerous measurements that we need to make in every given study all the time? And how completely did we report all of these things in the text of our body and in our summary statement? So there was both an objective as well as a subjective component to this, and there was a lot of space to put in any comments or any challenges that either of components of our team were facing. And lastly, to have the comparative statement and the call to oncologists. So this was taped out in March of 2017. So we taped out our educational sessions, including the checklist, including the protocol, and certainly going through in great detail where the measurements were to be expected. Potential cases were identified from ICD codes on our digital echo server. And thank you to my able fellow, Dr. Nelson, for going through all of these studies by the month. And then we picked 8 cases per month for 8 months before and after this particular intervention, randomly selected and reviewed for eligibility. Ineligible cases were replaced by the next one up on the list. In patients who had multiple scans per month, only the first scan was taken into consideration. Our exclusion criteria were quite finite in that any coexisting or preceding structural or functional heart disease. So we excluded patients who had hypertensive cardiomyopathy or who were already along the pathway of cardiotoxicity-induced chemotherapy, chemotherapy-induced cardiotoxicity, pardon me. And certainly anyone who had significantly impaired imaging windows. As you can imagine, this could be quite a big percentage of populations depending on the echo lab's ability. We tried to be cognizant and not exclude a vast proportion based on that, but if we had a baby who was absolutely jumping off the table, and we were unable to get any images that we could then have measured accurately, which we will actually say in our echo reports, these are likely somewhat compromised by patient's activity. So we removed those because the intent of this project was, again, not to pin the baby down or increase the number of sedated echoes that we do, but actually to improve our accuracy in those that we consider quite acceptable. Each echo was randomly assigned to 2 overreaders. This was a team of an echo attending, fellow, and sonographers. Thank you to all of them who participated. This was a huge amount of measurement we did overnights. Blinded to the original image measurements, all studies were overread at the conclusion of the entire study period. So that was a 16-month period. And the relative timing to the intervention was not specified, so we were as blinded as possible. Each overreader independently measured each of these parameters. So there are about 8 to 10 measurements that we had to make on each study. And they also rated the study for completeness of protocol, for the quality of acquisition, for the adequacy of measurements or the ability to make those accurately, and whether a communication was documented. REDCap was used for data collection. So here is some of our pre-post analysis. For complete acquisitions, again, as I mentioned, those are ones where we were pretty confident with where we could pop the calipers, where we could trace the endocardium in each of these left ventricles. We had a dichotomous variable, so all who had a complete acquisition got a complete acquisition. If the responses were no, we didn't get an acquisition, or yes, we mostly got it but not completely, those went into the no category. So we kind of were hard to ourselves or on ourselves. Similarly, for technical adequacy and the call to the oncologist. For this analysis, we used the first overreader ratings and in this prelim sweep of data. If the first overratings were missing, which is in only 2 cases, the second overreader ratings were substituted. The rates of each outcome was summarized by percentage over the study period, and logistic regression was used to compare the outcomes prior to and following the intervention. Now here's a little bit of our prelim analysis. As you can see, pre and post intervention, we seem to have really had a very nice uptick in the number of studies that were technically adequate. So we went from close to 52 to 67%, and this was approaching statistical significance. Acquisition complete, we had something of a ceiling effect in that we were already at 94% in terms of complete acquisition prior to this intervention with very little space for a whole lot of improvement. And so we don't have a statistical improvement to show you for that. A call to oncologist, as you can imagine, happens in only a small subset of patients. So these are very small numbers we're talking about. And in that, although we saw an uptick, this was not also statistically significant. To conclude, we did register improvement in echo technical adequacy, though we were not approaching statistical significance. I believe this is clinically significant to the patient in question. No significant difference in completeness of the echo. I believe that might be because of a ceiling effect, and no significant difference in communication documentation. Some of our limitations that come to mind as we were going through our prelim analysis is that we were not fully blinded. It was certainly possible if you tried really hard and you kept a track of when the intervention happened, that you could unblind and demonstrate some bias. We might have been underpowered to demonstrate significant increase in the adequacy component of our study, the ceiling effect that I was talking about a little while ago. And we have not yet separately ascertained the individual indications for call to an oncologist. Were we supposed to make one? And certainly the washout period of March 2017, when our intervention taped out, is not fully controlled. Some of our next steps are to expand on our pre-post analysis to account for the temporal trends via those fancy things that Sarah has just talked about, the interrupted time series. We also wanted to compare the variability of echo measurements following interventions with variability prior to intervention using SPC or statistical process control to identify evidence of any special cause variation. There will be some common cause variations. We were looking for any special cause variation too. And examine the concordance of original echo measurements with the mean. So remember, we had 2 overreaders. We're going to develop the mean overreader measurements and compare prior to and following intervention and compare the magnitude of the differences in the period prior to and following the intervention. So this is difference of differences. Really, to conclude, the next steps after all of this analysis really is a moment of introspection, is that right now, the timing is perfect in that there is a huge interest in our entire field around measurement variability, around measurement modalities, and are we looking for the correct thing with the methods that we know how? There's a lot of question about normality too. So what is really defined as normal? The range is apparently expanding a lot. So I think this is really interesting that we might be able to jump onto this bandwagon at a very critical point. The halo effect is very curious. As soon as we started talking about QI projects in the Echo Lab, we actually noticed that our variability in other more quickly reproduced analysis, and we have Ken here who has done a lot of that work, showing that variability in the other measurements that we were doing on cardiac structures and function in the Echo Lab demonstrably decreased. That was really very gratifying. I've been touched by the robust participation of our entire Echo Lab. There has been a lot of buy-in from the leadership. We made it to the SDI board for a long time. There is a lot of visibility to this project within our lab. And I think on the whole, it sets the stage to embrace QI and QI-related projects. So this was very insightful to our entire group and certainly to me. And I thank the QI Scholars Project for that. Thank you.
Thank you. For my project, I'm going to talk about our project in which we identified the optimal imaging protocol for suspected appendicitis. It is important to accurately diagnose appendicitis because there are negative consequences of both false positive and false negative diagnoses. False positive diagnoses lead to negative appendectomies, and false negative diagnoses lead to delays in care and an increased rate of perforation. Many imaging protocols call for an ultrasound as the first imaging modality because it is considered safer than CT with less ionizing radiation. However, ultrasound has a lower sensitivity than CT and relies on the technical expertise of the ultrasonographer to visualize the appendix. In the settings that use ultrasound, there is significantly in settings that use fewer ultrasounds, there is a significantly lower appendix visualization rate. When the appendix is not visualized on ultrasound, then the patient requires additional testing or evaluation, and this can increase cost. The aim of our study was to build a decision analytic model to simulate imaging protocols for the evaluation of pediatric patients with suspected appendicitis on a virtual cohort of patients. We used the model to evaluate the cost effectiveness of different imaging protocols for the diagnosis of acute appendicitis and to determine the test and test treatment thresholds and minimum ultrasound visualization rates to determine the cost effectiveness of ultrasound. I'm now going to walk you through one arm of our model for one of our imaging protocols, which is a staged ultrasound approach in which CT was performed after equivocal ultrasounds. In this model, we start with a hypothetical patient. For this patient, because it's an ultrasound first, we start by performing an ultrasound, which is shown in blue. The patient either has appendicitis or does not have appendicitis, and this is shown in green. When the patient gets her ultrasound, the ultrasound either is able to visualize the appendix, which is labeled non-equivocal and shown in blue, or is not able to visualize the appendix, which is labeled equivocal and shown in green. If the ultrasound is positive and the patient has appendicitis, then that is considered a true positive, and the patient correctly goes to surgery. This is shown in blue. If the ultrasound is negative and the patient did not have appendicitis, then that's considered a true negative, and the patient is correctly discharged. This is shown in green. If the patient had appendicitis, but the ultrasound was negative, then this was a false negative. The patient is inappropriately discharged and comes back with an increased risk of perforation, and the patient requires an additional ED visit. This is shown in blue. If the patient does not have appendicitis, but the ultrasound is positive, then this is a false positive. The patient goes to surgery for a negative appendectomy. This is shown in green. In this specific protocol that we're modeling right now, patients with equivocal ultrasound proceed to CT, which is shown in blue. The CT can, again, either be a true positive or negative, which is shown in blue, or a false positive or negative, which is shown in green. The possible protocols that we analyzed for this analysis were CT only, MRI only, proceeding to surgery straight without imaging, or a staged ultrasound approach. We considered two staged imaging approaches, one in which CT was performed if the ultrasound was negative or equivocal, and one in which CT was performed only if the ultrasound was equivocal. Our outcomes were costs and QALYs. QALYs are quality adjusted life years. Costs included imaging costs, cost of appendectomy hospitalization, and cost of ED visits. Our models were informed from published literature. Inputs included the sensitivity and specificity of various imaging modalities, the appendix visualization rates, and prevalence rates of appendicitis and perforation, and utility values. Costs were obtained from the KID database and Medicare standard costs. For our main analysis, we did a two-way sensitivity analysis in which we varied the prevalence of appendicitis and the ultrasound visualization rate. This allowed us to determine the test and test treatment thresholds for various imaging modalities depending on prevalence and ultrasound visualization. We varied appendicitis prevalence because providers can use decision rules, such as the PAS, to roughly identify the pretest probability of the likelihood of appendicitis for a specific patient. We varied ultrasound visualization rates to determine the visualization rate that would be cost effective. We can then use this rate as a target for future improvement activities. This is, again, that model that I was showing before, now showing where the two variables that we varied in our two-way sensitivity analysis occur. Again, blue is where the prevalence occurs and is accounted for in our model, and green shows where visualization is accounted for in our model. Next, I'm going to walk you through our results. On the x-axis, we're going to have prevalence, which right here is shown in blue. We varied prevalence from 0 to 100% of patients with appendicitis. On the y-axis is the ultrasound visualization rate. Visualization varied from a low of 0% of ultrasounds that visualize the appendix to a high of 100% of ultrasounds that visualize the appendix. The following slides show our results, and I will walk you through the results. The blue box shows when imaging by CT alone is cost effective. When the prevalence of appendicitis is below approximately 50%, again shown on the x-axis, and the appendix is visualized less than 88% of the time, again shown on the y-axis, then CT as the sole imaging modality is cost effective. For instance, as the arrows show, if the prevalence is 28% and the ultrasound tech is only able to visualize the appendix 50% of the time, then a CT alone would be cost effective. The orange box shows where a staged ultrasound is cost effective. In this approach, all negative or equivocal ultrasounds are followed by CT. For instance, as the arrows show, if the prevalence is 80% and the ultrasound tech is able to visualize the appendix 70% of the time, it would be cost effective to follow all negative or equivocal ultrasounds with the CT. The light green box shows where the staged ultrasound approach that only does CT when the appendix is not visualized is cost effective. Again, this is the one that I walked through in the beginning. For instance, as the arrows show, if the prevalence of appendicitis is 30% and the ultrasound tech is able to visualize the appendix 95% of the time, then it would be cost effective to do an ultrasound as a first imaging modality, and then CT only if the ultrasound were equivocal. Finally, the dark green box, where the arrow is now pointing, shows when it is cost effective to go straight to surgery without any imaging. This is only cost effective if the prevalence of appendicitis is very high, as you can see. In conclusion, we found that staged ultrasound can be cost effective for lower prevalence patients, but the ultrasound visualization rate must be high, at least 88%. In addition, if the prevalence of appendicitis is high, it is cost effective to perform a CT even after a negative or equivocal ultrasound, even if the appendix is visualized. This leads us to our future directions. Now we can create programs that increase the ultrasound visualization rate, particularly at low volume community hospitals, so that we can cost effectively perform ultrasound before CT. This study allows us to have a target visualization rate of 88%. In addition, our model does not account for the long-term cancer risk of CT. Our next step is to build an additional alternative model that attempts to account for these long-term cancer costs.
Thank you. I want to start by saying what a pleasure and a privilege it was to spend the year with this amazingly talented group of scholars. And you got a taste of Arthy's sense of humor, which just kept us entertained every month. And also their mentors who joined us for these monthly sessions, who were also just equally talented. And you didn't get a chance to meet them this morning, but it really was an awesome year. So I'm going to talk to you about an anaphylaxis score that I developed over the course of my year as a scholar. So during this year, I was working on two things. I was the owner of anaphylaxis clinical standard work, and that process, if you don't know, is a multidisciplinary approach to process improvement that aims to standardize care. And in the course of that work, we looked at many metrics to assess our outcomes.
So why did I look at a scoring tool for my QI Scholars project? That's kind of an unusual thing to do. It's not really a typical quality improvement kind of project. I am grateful to Rita for allowing me to choose that as my QI Scholars project. And the reason I chose it is that this was the most challenging aspect of the work we were doing in clinical standard work. We had a very time-sensitive need to have a tool that we could use to assess a patient's need for epinephrine, and there really wasn't an existing good tool, which we'll talk about, and this was really outside the scope of what we could do as part of clinical standard work. So I'm going to talk to you a little bit about why we needed a tool. Allergists say anaphylaxis is hard to define, but I know it when I see it. Well, that is fine maybe for allergists, although actually they disagree a lot between them, but it becomes increasingly difficult for those of us who are not allergists to agree on what is anaphylaxis and when do we need to treat with epinephrine. There is something called the NIAID or NIAID FAN criteria for diagnosing anaphylaxis, and they're fairly somewhat strict criteria. And I'm not going to go through it all, but if you meet these strict criteria, there's a good chance you have anaphylaxis. But this tool was never really designed as a clinical tool to decide that the patient in front of you early on in the clinical course needs epinephrine. It's kind of a tool that you can look back and say, given all of the information over a visit, yes, that patient was in anaphylaxis. And in fact, the people who made the tool themselves said there will undoubtedly be patients presenting with symptoms not yet filling the criteria for anaphylaxis, yet in whom it would be appropriate to initiate therapy with epinephrine. And there was also a consensus statement by a multidisciplinary group of experts who said basically the same thing. It is agreed that although these criteria are helpful in research, education, and risk assessment by allergists, they are of limited value for emergency physicians at the onset of an anaphylactic event, which may include symptoms associated with multiple differential diagnoses. The criteria also offer no guidance for identifying the patient with mild symptoms who may have impending anaphylaxis or be at risk of a future event. This adds complexity of decision-making around the use of epinephrine by the emergency medical services practitioner or ED physician. Despite this, these set of criteria are referred to in every guideline, every practice parameter for care. It's the only thing out there, so people talk about it all the time, such that is what we ought to be referring to, and it leads to this really discrepant use of epinephrine and confusion amongst our emergency providers and in any clinical providers, and we really need a better tool that actually is clinically appropriate. The challenge in anaphylaxis is that we really need to give epinephrine early. So we delayed administration of epinephrine is associated with poor outcomes and mortality, so we can't wait until the diagnosis is really clear. And so we need a tool to identify patients with suspected allergic reactions who warrant treatment with epinephrine, not patients who meet stricter criteria for anaphylaxis. So I set out to develop a tool, and I incorporated a whole lot of things that I felt were important features to incorporate into this tool. And I included the features that had been incorporated into the NIAID FAN criteria, features that had been used in care plans, which include a lot more kind of subtle, there's a much lower threshold for people in the community for giving epinephrine. Symptom charts that are described in a lot of literature. Food challenge stopping rules, which are quite different from the NIAID criteria. They have also a very low threshold for stopping a food challenge. For example, if you're itching, just a low level, a certain amount of itching, they'll stop a food challenge. And then an extensive literature review, which was part of our clinical standard work, to look at what had been done previously in score development. And this is the very first version of a score that I developed, actually, even before going into that clinical standard work process and that literature review. And when I first developed this, I thought I was done. I thought this was it. This was my baby, and this was so beautiful, and I was going to do a clinical trial, and I was going to validate this score. And then I became a QI scholar. And here's how QI scholars helped me. first of all, the didactics offered incredibly high-quality lectures by local and guest speakers, but that actually helped me. I have to say that helped me more with the whole process of our clinical standard work. More than that, helped me specifically with my score development, although there were, in many of those lectures, there were these sessions where we had to do kind of hands-on working through a problem, and we often got to work on our own project. So I would be sitting there struggling through a bit of my project, and then these awesome mentors would come and give me feedback on my project. We also had direct input on our project. Both we had to present it every few months, and we also sat down with our own mentors, so I got tons of feedback on my project. And a really good example of that I'm going to talk about is doing informal trials, and we got ongoing feedback and support, and then importantly, funding both for a statistician and for other things, which in my case is specialist input. So the really important feedback I got was, maybe you aren't ready for a clinical trial yet. Maybe what you ought to do is sort of N of 1 trials and just go down there and try your score with nurses and see how it's working. So I took my score down to the ER, and I would just ask a nurse to try it on a patient with anaphylaxis. And then you can see I'm writing notes of, oh, this isn't in the score, and oh, she struggled with this, and oh, I just said normal BP, and maybe I should be talking about, I really mean hypotension, not hypertension. And so I just took notes, and then I would fix it, and then I'd go back and do it on the next nurse. And I did it over and over and over again, iteratively, until it was behaving more robustly. And then it started to look like this. And then I thought, this is it. I'm going to do a clinical trial on this grade score. This is like 20 versions later. And then I went back to and presented this to my QI Scholars group, and they said, well, maybe you're not ready for a clinical trial yet. Maybe what you ought to do is some chart review and look at how it performed and get some preliminary data and test whether your concept, like sort of proof of concept, does this work the way you think it's going to work? So, deflated a little bit, I went and did a chart review of 60 patients in 2 kind of different groups, and I'm not going to go through the details of this, except to just say that it did perform better than the NIAID criteria, and it seemed to be relatively sensitive and specific, even on kind of a weird population that I chose to be kind of these mixed populations of patients in anaphylaxis and not in anaphylaxis. But in the process of chart reviewing these 60 patients, I also learned that there were more ways that it needed to be tweaked. So at the end of that, I tweaked it again. I went back, and now, I don't know, 40 versions, 30 versions later, something, finally came up with what I consider to be a robust version of this score. And then I went and thankfully the hospital was kind enough to allow us to integrate this into our clinical standard work, and it is now electronically part of the process of care in the emergency department and urgent cares as our algorithms for our clinical standard work. And a score greater than or equal to 5, basically, there's a detailed interpretation of what that means, but basically means give epi, and a score less than 5 means kind of observe and make sure they don't progress to needing epi. So clinical use to date, we've used this in 108 patients who were in anaphylaxis and got scored, and you can see that it's doing fairly, I haven't had a chance to validate it against a gold standard that's an ideal gold standard, which would be an allergist interpretation that the patient needed epinephrine. But I have validated against whether or not the patient got epinephrine, and I did that kind of as a proxy if they got it in minus 15 to plus 30 minutes of being scored, because how the nurses chart epinephrine is not time perfect. But using that as a proxy of a gold standard, being a little bit imperfect, the sensitivity is 84% and the specificity is 80%. So it's performing pretty well, and I actually think when we do it against a real gold standard, it may even perform better. So that work is coming this summer. That's going to be the end of my QI Scholars work, as we're doing a pilot study of that 108 patients where we will validate it against an allergist blinded interpretation of these 108 patients to does that allergist think they need epinephrine? And that work will then inform a large clinical trial to validate the score further. And that's it. Thank you very much, and thank you to QI Scholars.
Okay, we're going to bring all 4 of these brilliant young people, well, guess we're not all that young, but no offense, Arthi. Anyway, yeah.
Oh my gosh.
Down to the front. You can tell we had a great year with all 4 of them. They did some pretty spectacular work, and we'll open this up for questions. Oh, we got one right there.
Thank you all. This is always exciting to come to this particular lecture and hear about the great work. I've been in practice for 30 years, and I continue to be impressed by the fact that there's always things that we can improve on. And so thank you all, fantastic lectures. I suspect you've all been peppered with questions by your mentors and by your colleagues. So I don't have questions specifically for each one of you, although I was very interested in each one of your talks. I do have a question for Dr. Mangione-Smith. In an age where I think as a community physician we're seeing more and more burnout, and there's all kinds of talk about what to do about it, I'm a member of the Puget Sound Pediatric Research Network, which has kind of died, to be honest. We did a lot of outpatient stuff, and some good studies came out of that. But it's sort of withered, and I'm curious if there's a possibility of doing something like this for outpatient docs, community physicians, because I think it's exciting. We have tons of questions we ask almost every day. We have a wealth of patients that we could look at, but we need some help in terms of figuring out how to ask the right questions, which you all have done. And the statistical analysis completely escapes me. And so, thoughts on that?
Yeah, so we're, as you know, I'm division chief for general pediatrics, which is very outpatient. And one of the strategic initiatives that we have in the division is to try to reawaken a practice-based research network in the community. Obviously, we'll come to the PSPRN practices as part of that. And to really start trying to partner and have some of our younger faculty who are interested in joining this program say, okay, how could I use that as my laboratory? And really think hard with those practitioners about what's a problem that, like, you know, where's the need? What would we like to improve on? And, you know, use that as sort of the material for what they would study and work on, and at the same time engaging the practices. We really are trying to do this integration of, you know, all the sort of research expertise that sits in this institution with all the great clinical work that's going on in this institution, and really try to understand how do we work together to really make care better. Yeah, so absolutely, and we'll be knocking on your door.
Please do. Good. Thank you all. Very nice.
Thanks, everybody. That was really good. Sarah, I just had a quick question. You mentioned that you measured some covariables like race, ethnicity, and gender. Did you see any differences in that with the length of stays or the readmissions?
Because the sample size was so large, there was statistical significance across the board for those variables, but looking just at the numbers overall, they didn't change that much.
I'd like to ask more of a big picture question of what do you think would be the ability for those of you who are part of specialty divisions to continue to do meaningful QI as part of your ongoing job without external research funding? In other words, do your divisions see performing high quality QI as a necessary component in order to maintain excellence?
Yeah, no, that's a wonderful question, because I think it speaks to the sustainability of the program. So just having 4 of us sequestered and having a really great educational moment, I think Rita's vision for this, in which I can see translated into each of our projects over the course of the year, is that we walk in thinking that this is going to be awesome for mostly self-edification, and we walk out thinking that this is going to be a great responsibility I bear for my entire division. And I think during the course, I think these are, now again, since I'm talking the lingo, this is special cause variation. I think that the entire world of QI is also developing a lot of momentum. So I think it's a lot about timing. So I'm not sure whether the support that we are getting for our QI work within our divisions is a manifestation of that's what they were going to do anyway, or because now that they have a spearheading person or a few spearheading questions, that develops some more momentum. So, for example, in the division of cardiology, we actually, Ken is right there. Ken, you have to say hi to us. Ken is now most recently been called our MVP. That's how important he is to our division. And what Ken has done is he's restructured the QI protocols for all of our different divisions. So, we have EP, we have Echo, and even within the same division, we have lots of varieties of folks. And so he's bringing all of those attempts together. And I think my conversations with Ken have been very, very tangible in that it is a priority for the entire division. So that's to answer your political buy-in part of things. I really appreciate your second question about what about statistical support. And honestly, at this point, I think I'm not ready to be weaned. I'm not ready for the umbilicus to be cut, because I don't think in a year you can master, and this might be a failing of myself,
it's
but I don't think in a year you could give me a huge database and expect me to go through it and come up with something cogent. So I think that actually brings up a really valid point. What the program learned last year is that none of us typically will finish the project in a year. So Rita has very thoughtfully allowed a little bit of a taper into our program so we continue into our second year. And I dare say you actually learn more when you're off the program, because that's how long the gestation is for each of our projects. Funding statisticians and statistical support for SPC is valuable. I have been linked with a statistician who has been absolutely mind-blowing, and I don't think I would have had the insight into my own hopes and aspirations from my project if she didn't bring me back to ground and say, but how are you going to measure it? I think for all the divisions who are here, I think it brings up a really important point, is we have the political will, but we do have to back it up against in a more structural format with a lot of statistical support.
So Ed, I'm going to also just chime in and say my intention with this program is to go through the divisions and plant seeds, right? Seeds of people who are going to have some extra expertise, seeds of people who are now connected with the Research Institute and the people who know how to do this work and who can go to their division chief and say, this is a really important improvement project. I know just the statistician to work with. Can I have this much resource to work on this project? So I think institutionally, I'm hoping that as we try to integrate research and clinical care, that there will be support for this ongoing kind of work.
I just wanted to add to that comment. I'm first generation QI scholar in pulmonary. And I think that part of that is when we talk about aligning ourselves within our divisions, trying to speak what's the same values of the quality that we're trying to improve and speaking that language together, because I think what we're trying to work for is we aim a lot about our patient outcomes and we aim about what's good for the hospital, what's good for our patients together. But even though we all aim for things, we're not actually measuring the same things together. And so when we're defining those priorities, whatever that strategic plan is together, I think that part of that learning process and that gestation of this past of QI scholars, it all has to be at the table, and we have to not work in the silos that we often do.
I can just add one thing to that really quickly. It's been a great a privilege and a lot of fun to work across disciplines for my project. I've gotten to work with two of the members of the Division of Psychiatry and also Lori in emergency medicine, and it gives you a language to use with other fields and to work on a shared goal, which is great.
Thank you again, everybody, for coming and for supporting our scholars.
Thank you.